So there was also another study that was presented yesterday, the STAMPEDE study, which had an arm of androgen deprivation therapy with or without abiraterone and prednisone, also at 5 milligrams, and that also showed a very, very similar benefit. Now that was a more heterogeneous group of patients. It included, so Latitude just had high-risk patients or patients of poor prognosis, while STAMPEDE included patients without metastases, just rising PSA, localized disease, or just node-positive disease. So it was a more heterogeneous population. Despite that, they still showed the survival benefit expanding across the entire patient population. So some of these questions in terms of how do we apply this to clinical practice will be, do we just apply it to the patients with high volume or poor prognosis disease, or do we go all the way back to patients with just a rising PSA and apply this treatment to them? And there, I think we have to look at the pros and cons of the treatment. I think before, when we were using chemotherapy in combination with androgen deprivation therapy for patients, we tended to shy away from treating lower risk patients because of the toxicity of chemotherapy. But now that we have a much less toxic therapy with abiraterone, there may be more incentive to treat all patients that are starting on androgen deprivation therapy with a combination with abiraterone. But then we also have to weigh out the risks of the long-term treatment of abiraterone with prednisone, the toxicity effects over those 2 years that patients are going to be on therapy, as well as the financial toxicity of having to treat patients for over 2 years on this treatment. So I think these things are going to be emerging in how we decide how to apply this to our patient populations. I think it's a no-brainer for the patient with a high volume or high risk prostate cancer, metastatic prostate cancer. I think we should be able to start using abiraterone with androgen deprivation therapy now and instead of chemotherapy.